So the role of primary care, we all understand that how important it is. It guides everything else that should happen with a patient. And when we look at the quadruple aim, I can't think of any other business strategy that is working as well as the SpiroCare model that's working in Kansas City. I mean, it's improved the patient experience, it's improved the care team experience, it's lowered the total cost of care, and it's improving population health. And while there are other strategies that start to move toward the quadruple aim, United Healthcare has their Surest model, which is a great way of helping consumers in ASO business, having members find lower cost providers, lower cost deductibles, and still high quality care. It's still not quite what a payvider model can be when you have a closed loop system. And you may say, well, what about value-based care? And I'd say, well, value-based care hasn't quite lived up to what we hoped it could be. And there are a whole lot of reasons for that we're not going to go into today. But as you look at a trend, I think redefining how primary care is delivered and its role in our business is probably the number one trend. The second one that we're seeing is this, all the policy-driven coverage contraction and the financial exposure that's going to exist on both providers and on for payers. There's no easy solve to this. If this all comes to fruition, there's going to be a much higher amount of uncompensated care for providers, which is going to trickle down very rapidly to payers, and in the form of increased premiums among commercial insurance. And there's just no easy way around that. And then when you look at also tariffs on pharma and durable medical goods and medical supplies that are coming in from outside the country, this is all going to have a big implication, and we've got to figure out how we can manage that. And even a payvider model doesn't solve this one. I don't have a good solve, but it is a trend that's coming. The third one, and these are all kind of related, is how do we rebuild trust in this fragmented system? And there is a trust deficit. And I think while patients and members trust their providers today more so than they do their payers, because of the fragmented system, both sides of this equation start to have a trust deficit. And when you think about, what if from a provider perspective, we were focusing on how do we create the best culture? How do we create the best care, patient experience and through care navigation? How do we create seamless billing so there are no surprise bills? How do we keep patients in network, which would make everyone happy, including the payers? And not have surprise bills and keep everything a little bit tighter. Again, there's no easy solution to that, but it would be one of the things I would look at is how do we rebuild trust on the provider side as well as on the payer side. And then again, tech, AI, and the human interface. This is also not going away. And there was an article in the Star yesterday, the Kansas City Star yesterday, about this issue. And the risk isn't just confusion; it's also depersonalizing care. There is a role for AI, but it has to be built into a balance between the technology and humans and shared governance. For payers, certainly it's faster processing and better triage. For providers, it's more time for care, less lost time to friction. But we have to balance that with the human side. And we're still figuring that out, obviously, in many, many ways. And then the fifth trend, I think total cost of care can be seen as a unifying metric across payers and providers. I was in a conversation with a provider system a couple of weeks ago, and I just said, what if when a patient presented at the emergency room, you could, triage them as you normally do and say, you'd be better off at our urgent care, which is 50 feet down the hall. And there are certainly state regulations that can, complicate that in how that treatment can happen. But we have to think differently, because people are going to go the easiest route to care. And if we do see somewhere between 12 and 17 million more people, fall off of Medicaid, we're going to see more and more people presenting at the ER. And when they do that, we have to find ways of lowering the cost of care. So anyway, those are the 5 trends that I'm seeing in the category from all the conversations we're having with payers and providers around the nation. And I'm eager to hear the rest of our speakers today, and then get to the Q&A.
Thank you, Sharon. Thanks so much. It was terrific. Yeah, sure. And next we have Greg Sweat, Senior Vice President, Chief Health Officer, Blue Cross Blue Shield of Kansas City. And Greg, let's see if I can help you get to your slide. Here we go. Oops, I didn't do it right. I didn't do it right. It's good. And into presentation. Let's see how we did. We did it.
That's gonna look okay on you.
That is no longer on my screen, but I might be able to move it from my laptop. Nope.
Good.
It's not on my laptop or on this laptop screen. Let's see. Here we go. There we go. I think we're good.
Good. Okay, Beth?
Yeah, looks good.
All right. Thank you for having me here today. I'm really excited to chat. I struggled a lot with this topic when Pat and John called me about it. I thought, I'm not sure what to talk about. What's going to happen next month, let alone 5 years from now, because of the shape we're in, the stuff that's going on. And I think, Sam, thanks for the call out on SpiroCare. I think there's a lot of stuff that's going well, that has gone well. There's a lot of good stuff, and there's reason to be optimistic, but there's also a little bit of reason to be scared. And I think the question I kept coming back to is, am I ready? Are we ready for the changes that will occur in healthcare as we move forward? And it's not just the insurance industry, it's everywhere, because the stuff that's happening with Medicaid today and the redetermination, the work requirements. I was in a conversation yesterday with the Health Equity Learning and Action Network here locally with Kiana. And that crowd is, I think there's a high level of distress. And Mike Weaver said, what's happening in Medicaid is going to affect us all. And he's right, because I think as that kind of works its way into the system or the ecosystem, it's going to impact us. And I agree with Sam. I think there's a lot that you're probably going to hear consistently, but I just kind of started to think, well, where are we today? What are the things that are going on right now? And some of the things that just shocked me or staggered me a little bit are some of the things here. 2025, there's a lot of folks that are just not getting care, whether insured or not insured. People are skipping care, delaying care. A third of our teenagers today are diabetic or pre-diabetic. That should scare us all. There's a new hemophilia drug out there called Hemgenix. Have you guys heard about it? It doesn't cure hemophilia, but it creates factor IX for folks so they don't have the episodes that they have. It's nearly curative. It costs $3.5 million one time. It's a great drug. We should be able to give that to everybody, right? But it's $3.5 million. It doesn't work all the time, and it doesn't cure it, but it does help it significantly. The zip code disparity in longevity. Our best zip code in Kansas City versus our worst zip code in Kansas City for the most long-lived. Used to be a 12-year gap. Now it's 18 years. Horrifying. that that's what's going on in our city, in our own community. The M&A activity, and you know, Olathe is no longer Olathe. It's the University of Kansas now. You know, Liberty is as well. Now they're all owned by KU. That consolidation is occurring not only in hospitals, but in the insurance industry and vendors. And it's just constant and continued. It's kind of a topsy-turvy market. AI, we'll get to AI and talk about that a little bit. One thing I wanted to be cognizant of as well, but we have this massive advancement in innovation. When I was in training in 1994 or so, I'm family doc by training, primary care. I worked at the VA for a while when I was in medical school. And I still remember in 1994 having to go downstairs to get on the wait list for a CT scan that might take 6 weeks to get a CT. Today, you'd be horrified if you had to wait 6 weeks to get a CT scan or an MRI or whatever you wanted. But we get it now. The problem with CT scans are, especially if they're pelvic CTs for women, your increased risk for cancer goes up significantly. We think and we believe that if at the current rate today, there's 93,000 additional pelvic cancers because of CT scans, directly related. It's just, we need to be cognizant of the care that we seek sometimes. So there's a lot going on. There's a lot of good things going on as well. I won't go through the rest of these things, but I just suffice it to say, as I was kind of looking through just the stuff, there's a lot of stuff out there. I think we all would say there's a lot of stakeholders in healthcare. Each of us probably have a link to a stakeholder we would call, but providers, payers, and ultimately our communities and our patients, they're the ones that are really, really advantaged or disadvantaged by what we can do or don't do for them. Providers, there's a lot of provider dissatisfaction. The level of provider trust continues to go down. You see there's an exodus of providers. COVID certainly didn't help. We saw retirements go through the roof for providers. I don't know about you, but I've had friends call me or looking to us to help them find a primary care provider these days in our city because they can't find one. And when they do, they can't get in to be seen for 12 months or I heard somebody say they can't get in for 18 months to establish care with a primary care provider. That's horrifying. We shouldn't be like that. Payers, when I started at Blue Cross 10 years ago, I used to work over at Advent in primary care, trained at Mayo, back to primary care at Advent. When I started at Blue Cross in 2017, I was still learning the business. One of the great things for me was we started Spira Care. We called it Start Fresh, redo primary care. It was like drinking from a fire hose, trying to learn about the insurance industry. What I learned then is that of all of the people that we insure, about 60 to 70% of them were fully insured, meaning that they don't pay their claims. We pay their claims, we take the risk. Only a third of them, like the big people, think about the big guys, J.E. Dunn, Garmin, they just want us to pay the claim. They're going to take the risk. They think we can manage our risk, we'll help keep our employees healthy, and we'll take all the risk, we'll pay the claims. So from an insurance perspective, we don't make money on that. We just process and pay whatever they say to pay. We don't decide what we pay for them or what they cover. If they want to cover every plastic surgery possible, they do it. If they want to cover nothing, they decide that. We just do what they say. That's what's called an ASO client, or administrative service organization, or third-party administrator. We do it for them. Today, it's flip-flopped. 70% of who we insure today they pay their own claims. Small companies pay their own claims because they want to take the risk because they realize that these health insurance premiums are through the roof. They have gone up so significantly. I think they've gone up, if I remember right, 188%. Healthcare costs have risen 188% in the last 20 years. That's staggering, totally unsustainable. Our premiums year over year over the last couple of years have gone up 7 to 10%. We're not making money on that. Obviously, if you look at our annual reports, I'll be real vulnerable here right now. Last 4 years, look at our annual reports. Our operating income is negative, 50 million, 100 million, 80 million. This year, we're hoping to break even. And that's our goal this year from a nonprofit Blues plan, because a lot of the shifting that's occurring in this market these days is we're going from fully insured companies to self-insured companies. We're just trying to keep up with them and help them get through what they're getting through. So it's definitely time for change. And I think the question to us is, really, are we ready? Um, let's see here. Am I still right? 20 years, I just from a speed of change, I don't know about you. I'm old enough. Hopefully I don't look it, but I'm 57. I graduated from med school in 94, training in 97, and off to the races. I used to use one of these things, a cassette recorder. My kids wouldn't have any idea what that is. None. It was the best thing in the world because I didn't have to write the notes. That's not my note, but that's what they used to look like when I wrote them before having a cassette recorder. The great thing about the cassette recorder is I could get in my car and drive and just dictate as I was driving home. Then this EMR thing came out. As great as it is, it destroyed us from a perspective, my perspective as a doc. It's hard. But these are things that have kind of come and gone. The ability to train the way you train. This little thing on the bottom right is an arterial line. I still remember how I learned to do an art line. I don't think these exist today, but it was at the VA. A VA patient told me how to do it as a med student. Literally walked me through it as I was doing it to him. That sort of training doesn't exist. I'll never forget it. I know exactly how to do it. Probably still do it today based on the way I was trained. Today, there's so much technology helping people, probably not making mistakes like I did at the time, but things have changed so rapidly and so definitively. When I say, are we ready? I just want to give you some examples because I'm not sure that, are we ready? Yes, but can we stomach it to be able to change? There are drugs out there, like I mentioned earlier. There's this, and for those of you in outcomes research, and please don't ask me if I can get this right, but quality adjusted life years. Not many people have heard about that other than really steeped outcomes-based researchers. In Europe, European communities, they use quality adjusted life years to determine whether a drug is going to be utilized in their population. We know what those things are in our drugs, but we don't really care. Because if there's this teeny bitty chance that it's going to help my sister, wife, brother, son, we're going to use it. But over there, they're not. It's not going to hit a formulary. It's not going to even come to light. And a lot of times what they use are, I think in some countries they use, is it going to the average median salary or income of a family? If it exceeds 24 months, it's not even considered. Irrespective of the value of it, it's just off the chart. It doesn't come into play. Do you think we're ready for that in our communities to be able to get down the total cost of care? I would challenge us. I don't think we're there yet. I just don't think we are. Because the costs, the way they are going up, they're completely unsustainable. If you think about costs going up, like I said earlier, 7 to 10% every year over year, I don't know how we do it. Ethically, I'm sure you guys have all heard of CRISPR and the DNA and genetic code modifications that we're capable of doing today. I'm fascinated by it. I thought when Genentech came out years and years ago, and that first company, and that was really amazing stuff. I don't know that ethically we're ready for that. Are we? We struggled with the COVID vaccine, the way it functioned. You see what's happened with that. I'm not sure we're ready for that level of change. And there's a global smart pill market that's probably going to get into the 10 billions or billion number by 2028. They're ingestible pills that monitor your levels. So for schizophrenic patients today, there's a drug out there called Abilify. You actually, as part of the ingestion of that drug, it monitors your continued use of that drug through an app. I don't know. Are we ready for that too? Would you take a drug that's going to monitor your use or tell you how good you're doing? And maybe this room would, but I bet there's a lot of people out there that wouldn't. So I think personalized medicine is going to take off. The technology is going to, the opportunity, I should say, for innovation and the opportunity for advancement, the opportunity out there. In our country, we're amazing at innovation. The drugs that we're going to develop over the years, the innovation, the technology, the use of AI, it's going to, I think, dwarf our imaginations. Today at Mayo, when they do colonoscopies, they use AI to help the doctor diagnose. So when they're taking the scope back out, the doctor doesn't necessarily have to watch because the AI tool is diagnosing polyps and finding them for the doctors. That's impressive. That's going to continue on. And you all have heard about radiology being read by AI better, probably dermatology, pathology, And is there a day, my wife's a surgeon, I keep challenging her, I said, there's a day that a robot's going to do it better than you. That's true. And that's coming. They're able to discern microscopic changes better than the people doing the surgeries. You know, I think in some ways, you know, we're not ready for AI in many ways. Are we going to trust a robot to do our surgeries? Maybe we should, because they're probably not going to make the mistakes that potentially a human could make. So there's a big change on the way in innovation. The big data, I think data is going to be, if we can utilize the data. One of my shocks when I moved over to Blue Cross, I thought, gosh, they probably know what we're doing next year. I couldn't have been more wrong. We have data coming out of our ears. Very, very poor analytics still to this day. Analytics are the key, but I think the people out there creating the innovation in our space are going to be leaps and bounds ahead. Sam, I'm sure everybody's going to talk about the legislative changes. You guys are reading the papers just like I am. I think that's going to sweep into changes for us and how that's going to shape our healthcare future. There's good and bad there. I think we do need some legislative change to be able to afford ourselves, because I don't think we can afford the way we're going. I left the personalized medicine. I think there's probably a day where there's personalized benefit plans. We've bantered back and forth at Blue about how do we provide a personalized benefit plan that's specific to you, so that we know you as well as your physicians do because of the data that we possess, the predictive analytics that we have. There are spaces that we think we can tell you when you're going to get sick before you're sick. There are wearables out there in our community today that there are studies going on that they can tell if there's a guy over at St. Louis that's doing amazing work with wearables that he can predict when you're going to go to the ER before you even feel sick. That's really cool stuff that we need to take advantage of. I do think, I want to come back to the very beginning when Sam started talking about primary care. I do think the opportunities of primary care, we've known this for years. If you spend a little bit more in primary care, if you spend 10% more in primary care, these studies have been done, you're going to save 10% of the total cost of care. It's just, I don't know why we're blind to it. And I could be jaded because or a little bit tainted because I am a primary care doc. I think there's value there. And we've demonstrated in Spire Care. I think the day of primary care getting more and more engaged, it has to. We have to support it better. We have to grow it better, just like we have to support behavioral health. But from a primary care perspective, when we opened Spire Care, we gave the doctors more time. We wanted them to have the time they needed. We don't pay them on the volume that they see. All we do is we pay them on the quality and the cost and the value they preserve. When we first did the data shift about 6 to 9 months in to see, are they actually doing what we hope they'd be doing? Because we did spend some money on these things. We'd not done anything specific to change their total cost of care. And I thought it was going to be through the roof. I thought we were going to lose 20% by doing this. It came back and we were saving about 3 to 5%. We hadn't done anything different. We just told them to spend time with people. We told them to, if you want to talk to people on the phone and take care of them on the phone, take care of them on the phone. We don't care where you take care of them. Take care of them where you think is best. And so that's really the whole difference is time and a little bit of investment. And we've shifted it. We're not making money in Spire Care to the degree I'd love to, but it's supporting itself and it's changed the game a little. So I think in the end, there's a lot going on, and as you can see in the market, you can see legislative changes that are coming down the pike. Nobody's going to argue that we're one of the best countries in the world at innovation. You'll continue to see that in healthcare, I'm convinced. In the provider space, the payer space, and our communities and our patients, we've got to figure out how to create trust again, partnerships and alignments, or we're going to struggle. Because right now, and I'll tell you, you've seen it in the papers. When I first started at Blue Cross, there weren't lawsuits and terminations and fights and arguments. We had conversations. That is not happening today. Suffice it to say, we're interested. It's just it's harder and harder because of cost increases. So I guess I would leave you with the question is, are we truly ready for the changes that not only have to occur, but will occur? I think there's reason for optimism.
Thank you, Greg. Lee?
Oh.
Thank you so much, Greg.
Yeah.
Everyone, Lee Norman is coming to speak to you.
not my slide. Well, I have no slides.
Sorry, I should have done it. Boop, boop.
Do you have to do boop? Do you have to say boop?
Yeah, I do, watch. Boop. If I could get the mouse to.
I don't care if you
Can't get
boop. I don't care if you boop or not.
I'm trying to get the mouse to reveal itself. I can't get the mouse. There.
All right. Boop.
And how about we get rid of that in there?
Okay. Hey. Greg, so nice to see you again. Been a while. My name's Lee Norman, Norman. I'm up there somewhere probably. Anyway, I decided to not have slides because I knew that Dr. Sweat would do it so well that anything I would add would be superfluous to whatever it was he did. But I'm so happy to have a conversation. I come to these meetings a lot, as you guys know, or may know. I've been around a while. I was a bit of a doctor for, I don't know, 45 years, give or take. Chief medical officer at Swedish in Seattle, and then here at University of Kansas Health System. I was on Governor Kelly's cabinet, ran the COVID response for the state of Kansas for those 3 painful years. And I'm just so glad to have an opportunity to have a conversation. And that's why I didn't tee up a bunch of slides, was because Dr. Sweat and I, we're kind of a mutual admiration society in the sense that there's so many things that we see in common. And yet one of the things that, and I've spent 40 plus years on the 501c3 nonprofit side of the equation. And just for these last 3 years, have I been with this company called Optum. Oh, there it is. It's right there on my chest, actually, which is a for-profit company. And I had to prove to myself that this is something that I can make it work out. Before I came aboard with Optum, a little over 3 years ago, I flew out to Vegas and then Los Angeles and Albuquerque, and said I wanted to see that the for-profit and the not-for-profit side can kind of meet in the middle on something, because it had to be proven to me. And I think because since the mid 80s, what I've known, and it's what Greg just talked about, which was there's got to be something in the middle there, which is, what do we do that really works well for patients? That we all have high quality outcomes, and yet somebody to spend more time with patients, it really makes a lot of sense and pencils out for them to, did I mention this, spend more time? And I finally came to realize that there's this value-based care thing is actually, if it can pencil out, makes a lot of sense. And I'm very, 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 oh, my dog sat on my glasses. So if I keep doing this, and I have trifocals, damn dog, sat on my glasses. I really, really believe in where we're going. And I'm a retired Army colonel. Let's start with that. Only 50 years in the military, 48 actually, between Air Force and Army. Why do I bring that up? Well, some of the most favorable things I've ever seen have been from my military experiences, but it's not necessarily confined to the military, just because we we need to really, to Greg's point, great. I'm a family physician, a great primary care. I was actually a social worker before I went to medical school. And then the Vietnam War came along, and I said, well, shit. I actually, that's exactly what I said. And then I got a low draft number and went in the military during the Vietnam War. And it changed everything. Why do I bring this up, Lee? And the reason is because the things that Greg mentioned and Dr. Sweat talked about, which I think are so critical, is that the tenets that we adhere to, I don't care, from my years as a social worker, years as family doc, years blah, blah, it's or chief medical officer at Swedish Health System in Seattle, or this little place up the road here called KU. I was there for quite a number of years. And the reason I bring it up is because the same tenets that we hold on to are the ones that we hold on to, that's why we are here. And so I'll be I actually am in my 70s. You may have done the math on that. You're doing your math, aren't you? I can tell you. No, not me, sir. But the reason I bring it up is because the same things that we hold on to are the things that we hold so very, very dear. And I really pretty much love what we're doing in value-based care. I mean, we haven't got it exactly right yet. I'm soon to be entering. I told Optum when I came aboard a little bit ago in 2022 that I said I would stay 2 years. I was in my 70s. I still am, actually. I know, yeah. For those of you not in the room, there's somebody over here that must come from I don't know, actuarial background or something. No. We'll get back to you. And the reason I bring it up is because it's I've been so blessed to have all these different facets between civilian and military and KU and Swedish and these other places I've been. But one of the things I really appreciate, and Greg and we've met and talked about this before, and that is how do we really make value? We use this term value-based care, and value-based care, it depends a lot on who you're talking about. I mean, if you're talking about from a patient's perspective, I can guarantee you, I know what value-based care is like from a patient's perspective. Although I've not been a patient, thank God. But what is it that we can do from a caregiver's perspective that makes value? And Greg comes at it from the perspective of the Blues. I come at it from this little tiny company known as Optum, otherwise known as United Healthcare, owns us. And yet we're not. We have our multi-payer. So we have United Healthcare, yes. Humana or Aetna or other ones that are also providers to us that are the payers. But the question, and I think the question came up, is what is the difference between a payer and a provider? And so when I first went up to my old buddies at KU, it was like 2 or 3 years ago now, they said, so are you going to be a competitor or a partner? And I think that's a fascinating question. And I, of course, answered the question, yes. And that is that we might not be an insurer. And I can guarantee you that we Optum Health, we call ourselves a provider organization. And yet we are a risk-bearing entity. So when a United or Humana or Aetna or whoever comes to us and says, "Hey, Lee, and would you take on this book of business, this membership, these patients?" Sure. But we are the RBE, the risk-bearing. And remember this, RBE, risk-bearing entity. We are the RBE for whatever membership. It's taken me only 45 years to come to that term, membership. I call them patients, come to us. So are you, Lee, a competitor or a partner? And the answer is yes, because they come to us. It could be from United Healthcare or Humana or whatever, and they say, and then we're allocating these memberships to you, but you're the ones on the hook then to make a go of it. So I've decided that we are, yes, a risk-bearing entity. We Optum. And there's a blurring, God dang dog that sat on my glasses. But we are a risk-bearing entity that therefore means that we are very, very, very much like an insurance company. And we have to think that way. So, what's going out this door, what's coming in this door. So, only 43 years of my life have been on the purely caregiving side of the equation. These last few years, maybe on the RBE side. So I'm really happy to be where I am, but it's a different kettle of fish, and I'm getting the hook. Thank you very much. I appreciate it, John. It's said. Hey, buddy. How are you? How are you?
I had no idea you were the CMO at Swedish. My
Only for
internship
14 years.
My internship and residency was there, and very formative.
You didn't have gray in your beard at that
Oh,
time.
thanks for rubbing it in. So our next speaker is Ashok Subramanian, and what a pleasure it is to have you. I just need to figure out how to get you access to the slides.
I will run it on my side if that works.
Yes.
That would be great. Thank you very, very much. And we're looking very forward to your perspective on provider to self-funded employees and the future of healthcare.
No problem. Is my screen showing up appropriately or the same problem as before?
Oh, it looks good. Just going up. Now it is not doing what
You're in presenter mode.
you're.
Yep. Give me a second.
Great.
Better?
No, not yet. There you go. Perfect.
There's
Thank
a bit of a time lapse. We need AI to fix that. Well, thank you. I'm going to be, I actually have the advantage of going last. And so I cut down a few slides given the prior discussion. So it's a real privilege to go after the first three speakers, but Ashok Subramanian, CEO, co-founder of Centivo. I think all of the messages today are absolutely on point. So I love how Sam opened with respect to some of the trends. One of the only things I would add, because I think all of those trends are spot on, is this idea that the thirst for affordability in healthcare is higher than ever. Simply put, we've effectively lost a generation of wage growth in this country from the fact that healthcare costs have risen so much. And I think the efforts by Casey Blue and Dr. Sweat and SpiraCare are absolutely on track. And I think some of the results that you heard him speak to and some of the challenges and some of the areas of concern are spot on as well. So what we've tried to do at Centivo is create a tech-enabled solution to bring some of those macro themes into a package that's accessible for companies of any size. And at the end of the day, you know, I often joke, those of us who've been going to these types of conferences for 30 plus years have been hearing only bad news about healthcare. And it's hard to change that into a call to action. And so what those of us who are practitioners need to do is try to keep it simple, try to take those themes, try to take those areas of opportunity, value-based care, primary care, et cetera, and put it into an easy button that almost feels like you're buying a shrink-wrapped piece of software, you know, from the shelves of an office supply store. So we tried to do that with a clean sheet of paper, and our North Star, our moral compass is the half of working America that doesn't have $400 in an emergency fund for any expense that's unexpected, let alone the ability to fund a $1,500, $2,000, $3,000, $5,000, $10,000 deductible, which sadly is becoming ubiquitous in in modern times. So the way that we thought about building that package with, you know, for those employers that, as was mentioned, about 70% of whom are now self-funded, paying their own bills. I love the idea. I love the way Dr. Sweat, you spoke about that. Was to create a 4-part program. And that 4-part program is to use technology at the front end of the experience around a digital primary care approach. So we first did this by building our own team, licensing software for patient communication, for e-consults, for using Athena as our EMR. And then we decided that it was working so well from a cost and a patient experience perspective that we actually bought a company. And that company, Eden Health, now rebranded as Centivo Care, has allowed us to span one of the first NCQA certified practices from the perspective of being a patient-centered medical home, the ability to now do that across 50 states and to integrate behavioral health, to integrate urgent care, and to integrate true primary care. So the types of relationships that were spoken about earlier that are trusted, that are longitudinal in nature, can be done digitally. And one of the most exciting parts about that is we have found that the users of a tech-first primary care service are actually not who you might think they are. You might assume they're 22-year-olds. You might assume they're people who are coding until 3 a.m. Actually, what we found is it's the folks who have the biggest challenges with access. Folks who work 2 jobs, folks who are single parents, and for whom being time poor is as significant as being cash poor. And so we've really used that idea of this tech-first primary care, and we work with local primary care in the communities as well. We're proud to partner with Centris Health. And so you can see a local provider anytime you want. And if you never want to use a digital service, that's fine. But we found that it's really redefined access, and redefining access to us, as several spoke about earlier, is at the center of changing the cost curve and reimagining this radically affordable proposition. The next thing we do is we contract directly with providers for those things that cannot be provided virtually. We'll talk a little bit about that in a moment. The third is we administer the plan based on a product and a process that is entirely built on modern technology. And then the fourth is to enable some of those smaller employers to get the advantages of those larger self-funded companies that have their own risk pools. We've created the ability to pool larger claims. We do that for those of you who are technicians, in the form of a captive. But that allows a business to have some more stability if that organization of 100, 200, 300 people have 2, 3, 4, 5 large claims. They're somewhat insulated from the shocks of those large claim costs. So you can see some metrics on the right. The one I'm most proud of is the second one. So it's this idea that 2/3 of folks who follow our plan rules, and I'll show you a sample plan in a moment, get under $100. So almost imagine you go to the ATM, you pull out a $100 bill from there, that $100 bill being able to cover the full out-of-pocket costs for 2/3 of members, very much tied into this digital first strategy and the ability to then steer care into the most high quality, efficient providers in any given market, including those we partner with in Kansas City. We've spoken a little bit about the idea of primary care, but what we've really tried to do, and it's been a little bit of an uphill climb, is that all telehealth or all virtual care, if you've heard those terms, is not created equally. So how do you create a more accessible way to get what some of us who are so fortunate might be able to get when you have a really special relationship with a provider, almost a concierge level of service and support? And so we've done that again with this idea of using the asynchronous ability to message with your provider, not a random provider, not someone who's logging in for 7 minutes while watching a football game at halftime, but someone who knows you, a team that knows you. And one of the other stats that's been really intriguing about this redefinition of access is, there are 6 conversational chats for every one synchronous video visit. That to us sort of speaks to how people want to engage in modern times with people they know and trust. Most of you probably have a group text chain of fantasy football buddies or moviegoers or whatever it might be. And I'm guessing there's a whole lot more of those texts flying back and forth for every FaceTime call that you're doing. Same sort of concept brought to life for primary care, again, with the idea these are people who know and trust you, so you don't have to start over with the conversation. So that's a key part when you build that trust on the front end, whether it's physical with a local provider, whether it's through a clinic like what SpiroCare has done, or whether it's through a digital model like ours. Then you have the ability to work with people, since you've built that trust, to get them to the care they need at the right time in the right place. And what those of us who are practitioners know is that all care isn't created equally inside a broad network. And so I've used to take some of the political, temperature down. I've used a out of area example. There are examples like this in your market and every market in the country. But here's a pretty accessible example in Dallas, not too far away, where literally the exact same code. This one is for severe sepsis. You could redo this for a C-section, for a normal delivery, for a spinal fusion, whatever you'd like. But you can see roughly 50% variations in this example. And it's not a particularly cherry-picked example, but there are large variations in unit price without material differences in quality. And oh, by the way, this data is now fully accessible through what's known as machine readable files, what's known as the price transparency regulations. They're hard to get to, but we can now better use the trust at the front end from the primary care perspective and the ability to drive care to efficient sites of service and efficient providers based on unit price. And so what's the net of all of that? You pull that together and what we call the partnership plan, again, that partnership with local providers, with primary care providers, that partnership plan is able to deliver a level of affordability that for those of us who are old like me, you might be able to, this might look familiar to a 1980s style benefit. A relatively low out-of-pocket maximum, $0 primary care, $0 specialists in many cases. We give the employer the ability to write these plan rules as they would like. Not every employer takes our advice, but we're looking for a very, very radically affordable benefit level, what's known in the industry as a 90 plus or a platinum level actuarial value, which again, for the normal person, it just means expressions that we've gotten are things like, wow, like it actually feels like I have health insurance again, as opposed to how come I've spent so much money on health insurance and I still have this big bill I have to cover. So those are some of the exciting things that we've been able to do. We've started to market in Kansas City. We work with a number of employers like Nebraska Furniture Mart, the Paola School District, a few others, and we're excited to keep growing. And I'll close on this. To us, what everybody has talked about today are exactly the right themes for how we can reinvent healthcare, health insurance, the provisioning of healthcare. But what motivates our team, what motivates me is to really put that in the perspective of the individual. How are we making someone's life better? Someone who's a colleague of ours, someone who's a family member of ours, our mom and dad, whatever it might be. And these are examples, I won't read them all, but these are examples of people that we've had the good fortune to be able to care for and not only help them again from a care perspective, but to remove the anxiety, to remove the feeling of self-doubt when you have to get care and you have to worry about the medical bills. We all have the ability in this room between our resources, between our capabilities, with the technology know-how, and now the information with these variations in cost to be able to do something about it and to not have cost get in the way of people getting the care that they need. So thank you, all of you.
Oh my gosh. Thank you. Thank you. Thank you, Michelle. Centivo's creating exciting trends indeed. Thank you so much for that. I'm going to let Dr. Spertus take over, and we do have some questions. Do you want to
Okay, I do.
hang on there for a second?
Sure. Well, first of all, thank you so very much. I mean, these were great perspectives, huge challenges. I had a bunch of themes that I was going to try and weave together. And, Ashok, I'm going to definitely have to learn more about Centivo. It's very, very, very interesting. I also, in the audience is Matt Bunty, who's got a very interesting story. So I hope you'll speak up. But somebody who is a high-cost peripheral interventionalist who left a traditional practice to actually really completely immerse himself in value-based care. So, but Pat will kill me if I don't go through the questions online first, and then I'll be able to take over. So there's a lot of, so Greg got a lot of questions about Greg, how does a payer know where to start? How do you determine what business strategies are number one, number two, number three? I don't know what they were referring to, but it's clearly challenging. Just one CT scan can increase the risk of pelvic cancers? Really? And do you think qualities are the way to go in the US, or what measures would be appropriate to capture cost effectiveness across the wide range of payer segments? So those you can choose from among those. But I don't think that one CT causes pelvic cancer. It's remarkable how many radiologic studies people get, and there was a very interesting study looking at this, at the variability of this across the country, that leveraging Medicare data. And, the Medicare population, I mean, some people are getting, over a dozen scans a year. I mean, it's amazing how many scans sometimes go on. And so I think they were looking at the increasing growth of CT scans over time, and then projecting what the impact of that would be on radiation sensitive cancers. But I think, the idea about payers prioritizing different business strategies and thinking about cost effectiveness. So if you could address some of those.
No, I appreciate the questions. Thank you, John. I think the point about the CT scan is not that CT scans necessarily cause cancer. The point is, be careful what you wish for. I think we need to be cognizant of the fact that, I practiced, I get it. People would come to me and say, I'm curious about my blood type, or I think I hurt my back. This is a true story. I moved back here. Somebody jumped up on the table and said, the urgent care doc said you'd order my MRI. This person jumped up on the exam table better than I could have. I thought, are you sure? I think let's wait on that. No, they said you'd order it. Most doctors at some point are going to say, you know what? It's not that big a deal. And they write it. I don't want to talk about prior auth for a lot of reasons, as you can imagine. But I think unfortunately, there's a part of it that's probably necessary for some reasons. And some of the things that I don't think people understand about prior auth is, when I said earlier about the companies choosing, they do. We don't even look at them. They come through as administrative denials. They don't even get to the doctors. They don't even get in the system. They get checked no because the company said no. So there's a lot to that. But I think, the question about where do we start? I think if we don't address affordability at some point, at some level, these increases in cost of I said 10%, it's actually 13%, 7 to 13% increase in premiums. You guys are going to feel it. You're going to pay more next year. You just are. Your companies will, and you will. I am. I know we are, and we're going to continue that trend. When we're getting at you, if you didn't hear about MU and Anthem fighting over the last few months, you missed a big thing. If you get a chance, go listen to the Senate hearing, a 2-hour session that's just like a podcast, very interesting. But when that's the challenge that we're having, is a 42% increase over 3 years. And Anthem, they're in the same boat we are. A lot of they're not paying the claims. They're just paying them. I mean, they're just paying the claims. They're not footing the bill. They've got employer groups footing that bill. And so I don't know how we solve that problem without addressing affordability. I think that's primary number one. No, and I told you during the talk, I wasn't going to address the quality adjusted life years. Happy to talk about it, but like you guys know this better than I. Is that the solution? I don't know that that's the solution. I'm just telling you that's what a lot of the European communities and countries have been using to justify adding medications to their quote unquote formularies. Otherwise, they don't use them. They don't add them in. I don't know that we're ready for that because we kind of get everything we want when we want it. You know, the single payer system, is that the solution? I don't think so. Unless you want to wait. I think the average wait for a knee surgery in Canada these days is 291 days. You want an MRI, it's 161 days on average. I don't know if anybody's going to put up with that in our communities. So there's challenges, but I think the first thing we've got to address is affordability. We do a pretty good job. I mean, I wouldn't say we're the best at quality, but we do a pretty good job in a lot of cases. We can do better.
So great. You know, I will say that, you know, over testing and iatrogenesis is sort of the bane of my existence. I spent my entire career trying to support that. And, you know, I think that is a challenge, is that when you invest in doctors having more time to talk to the patient, so the patient really is understood, is heard, they don't need a test, you know, but the doctors will order the test if they don't have much time, because then they've done something for the patient, you know, and then they go on to the next patient. And, you know, to me, I had never understood why payers did get way behind telehealth much more aggressively. COVID was a great example. We did a lot of studies in atrial fibrillation and heart failure to show no difference in outcomes. But if the patient isn't in the doctor's room, the doctor doesn't feel as obligated to order another diagnostic test or another study or an extra lab test that aren't really going to influence their management because it's more inconvenient for the patient to go get it. That's care that's expensive, that's not really necessarily affording much value. But the first, Ashok had a novel solution to a problem that I really wanted to bring up because Sam brought it up, talking about total cost of care as a unifying metric. Greg brought it up about precision medicine and its promise to tailor treatment to risk. And Lee brought it up, talking about sort of, you know, the multiple perspectives of value-based care. And what I struggle with is that, you know, hospitals who are major partners in contracting don't know what it costs to deliver care. And so the only, and this is unfair, we don't have a hospital perspective or representative here, but I'm going to go out there and just say, they just know they make 1% to 2% profit. The greater their top line revenue, the more money they make, and that's how they sustain themselves. And, you know, the insurers are very incentivized to try and lower the total cost of care so they can don't have to have these year-over-year rises in premiums. Precision medicine is an example of something that, you know, could definitely avoid sort of iatrogenesis, explain the difference in outcomes of going to back surgery or not, or, you know, going to the cath lab and getting revascularization versus medical therapy. And yet, you know, if that kind of shared decision-making engagement happens in a clinic, the hospital gets less procedures and gets less revenue. And so there has to be, and value-based care has never had the trust of both parties, because as soon as a provider saves money, then the next year that becomes the new threshold and they can't make money. So they want to keep the value-based care to be, the payments be as high as possible for as long as possible. And it undermines everything. And so my question to really all four of you is, how do we align incentives? How can we clarify the opportunity in a trusting way where the providers can make greater margin, so they're focused on margin instead of top line revenue, that the total cost of care can go down, and that patient outcomes would likely really improve? And so I'd love to hear from all of the speakers about, what do we do when incentives are so misaligned, and how do we move forward in a way where, I mean, you know, at High IQ, our whole sort of mantra is, by bringing all the stakeholders together, we could have a win-win-win where patients get better care and outcomes, where the cost of care goes down, but the profit for hospitals and providers goes up. but we haven't been able to sort of crack that nut. So I'd love for the four of you to solve that for me.
Easy question.
All right, Ashok, you've probably got the solution. So you're not here, they're pointing at you. And then Sam, you're going to follow, and then we'll pick on Lee and Greg here.
Well, look, if I had the solution, then my Buffalo Bills wouldn't be 0-4 against your Chiefs in the playoffs. So
We do love that, by the way.
Yeah, I don't know about that, but one of these years, Josh will get it done. So look, I think Sam had some really good language, and so I want to let him speak for himself. But this notion of payvider and this notion of really integrating the ecosystem between care and finance, we've seen that work. We've seen that work with Kaiser, although they're having some high renewals, but generally speaking, they've done a good job. We've seen it with Intermountain Health in Salt Lake City. So in my mind, one of the things that we try to do is we try to have our cake and eat it too, because we want a big, broad, open access network, and then we want cost control, and those two things are hard. So I feel like we need to go into one of two very distinct lanes. Lane one is a payvider style integrated grand bargain, which is you will get care in this way. We've tried to create that with this virtual first, digital first model and a subset of providers. That is our tech kind of enabled version to a payvider in the 21st century. It's curated, it's narrow, you're not going to have unfettered choice, but oh, by the way, you're going to get some cost control and affordability. The other end of the spectrum is to basically say it is unfettered open access. And in that model, I think we're just going to have to give people much more visibility and ownership over the fact that you've got these big price variations. So one of the things that we've seen that's intriguing is the use of cash pay as a corridor for employees to basically say your catastrophic stuff is taken care of, your primary care is taken care of through a direct primary care model, what have you. But I'm going to basically give you $5,000 to cover that middle ground. And if you can limit what you spend, then you get to keep some of it. And that allows people to start to look at those variations in things like MRIs and CT scans and labs and so on. I don't think that's a long-term solution with the aging population, which is why we're on kind of the more of that virtual payvider side. But I think ultimately those are the only two ways you can get there. And the status quo is not going to reward people for controlling cost.
Well, that's shifting a lot of responsibility to the patient. You're giving them the transparency to make the decision. But as a type 1 diabetic, $5,000 isn't going to go very far for me as the limit, assuming I don't have some catastrophic event. Sam, what do you think? What is your sense of how we could create better alignment between payers and providers, especially in an era where there aren't as many payers delivering healthcare?
Yeah, it's a great question, and I think it's the actual crux question of this whole session is how do you find a way to align those? Building on what Ashok just said, I think, and again, it's not a long-term solution, but I think an ICHRA solution is also a potential short-term solution where you're taking, employees and basically moving them into the exchange, and Lord knows what's going to happen with the exchange. But it's there, and that can help control the cost of care. What I think is interesting, and I know there are individual market and state regulations that could challenge this. But again, one of the conversations I had with a provider organization last week was, what if we could guarantee, if the provider could guarantee that when a patient has a procedure, that all of those provider costs will be in their network. If you just think about what that would mean to the patient, of getting rid of surprise billing, getting rid of costs that are not involved with that are out of network to them, what that would mean to payers who don't have to deal with all of it's out of network, it's in network. And to me, it is one of those maybe little small frictions that could actually have quite a bit of impact. I also appreciate the comment about Kaiser. I think what Kaiser did now, almost 80 years ago, when they first started that business model, which means it's not new. It was brilliant, but one of the challenges they have is it's everything. Okay. And the thing that I love about SpiraCare and Prosano Health and other payvider models is it's primary care. And if you can tie a payvider model to a narrow network that's still certainly robust enough to treat everything, and have the care guide involved so that you're navigating to the right, specialists, then I think you can control the total cost of care on the certainly on the payer side. The provider side, it's the provider side
mean,
is actually much more complex. Yeah.
Well, and it is still challenging. I mean, primary care is a great gateway, but boy, once you get to, St. Luke's, KU, whatever, for cardiology, at least, you're gonna get everything under the sun. And that's what Kaiser's trying to get. And I'd like Greg to talk, and then I really would like to hear from Matt. So we're gonna hear a completely different perspective than everyone else.
Thanks, Sean. Ashok and Sam, I do agree with you. I think there's opportunities in the payvider space. Clearly, I firmly believe that you have to have that alignment. That partnership is important. The shoppable experience, I think that's important as well. The unfortunate piece is there's probably 20% of the healthcare experience is probably shoppable to a degree. We can post pricing, we can post some level of quality, distance, et cetera, and we can let you go. Part of the problem there, I think, with shoppability is unless somebody's actually paying for it, because if it's just a copay, it's only $50 more to go there, or $20 more to go there. It may not change behaviors to the degree that we would like. The one thing I think is that we're not here yet. We've dabbled in it, we've played with it a little bit, is truly defining quality and value across providers and systems. I would love to see this as a payer. I'd love to see billboards and magazines and websites posting, let's say, endocrinologists. Every endocrinologist in Kansas City, all the complications that they have, their A1C success, the cost that they have, what their payment rates are, and then we can all naturally choose where we go. Because I would argue that if it's an orthopedist, for instance, or an endocrinologist, from a knee surgery, that knee surgery that they're going to do is, although it's not garden variety, it's a knee scope, it's a change, it's a knee replacement, it costs X, and that person only has one complication per 1,000. I would drive from Liberty to Olathe to have that done. I wouldn't necessarily go to my backyard and say, hey, who did your knee last year? Did you like them? I did. That's not the place to go. I think there's a way that we can start to maximize data, publish data, because doctors are gifted. I mean, they want to get the A+. They always have. They're just kind of genetically wired that way. So if you give them that to go to, that's what they're going to go to. I had a conversation with somebody at Children's Mercy probably 6 years ago. He said, Greg, if you want to change the way you pay us, tell us. If you want to move to a totally value-based option, and you're going to do that in February, we will figure it out. So somebody just has to have the chutzpah to do it. And that's what it's going to take, is to move.
But that's on the provider. I mean, you haven't heard that from, research and Shawnee Mission. And
no, but it just takes, that's why I think there's going to take some whole scale change, whether it's our legislator or our leadership, to say, this is the way we're going to do it from now on. CMS has put out this is the way we're going to pay relative value units. There's work. It's just, that's what doctors go to. If you pay me on RVUs, I'm going to do as many as I can. If you pay me on quality, okay. Not to say that they're not altruistic, because they are to a degree, but they get paid over here.
No, I completely agree. I have you come up, but I will say this, it is very easy to quantify for a CFO the RVU somebody generates. And so they pay an RVU-based model. I mean, and to me, that completely misaligns a lot of our goals. And so, in disclosure, I'm on the Blue KC board. So, Greg's heard this a million times from me, but my belief is that there has to be a way, this could probably be done better in Kansas City than almost anywhere else, where there are real payer-provider partnerships, and there's an effort to maximize the profitability while lowering the total costs of care. But to do that requires, for example, a St. Luke's to completely rewrite every physician contract focused on value instead of RVUs. I mean, there has been an evolution that has taken us and so misaligned our incentives. And Rob Califf, who was the head of the FDA for years, has been sort of a friend and mentor for a long time. Kept saying, I asked him some of these questions. He said, the healthcare is so bad. We pay more of our GDP, and we have the largest GDP in the world. So we pay more money per person by far than any other country in the world. And our average survival from birth to death is something like below Chile and above the Eastern Bloc. It's terrible. And, we get terrible value. And we were talking about it, just this, it's all about the lack of incentive alignment. And, we're going to have to figure that out. And speaking of somebody who wants to think about a new model of incentive alignment, I'd love for Matt to describe a little bit of his journey and vision, because he's a provider in the trenches who has taken the leap to get out of this traditional healthcare reimbursement model into a value-based practice. So,
Thank you. Thank you, John. My name is Matt Bunty. I'm a freelance interventional cardiologist right now, I'd say. First, I just want to acknowledge Stacy and John, who frankly have given me the confidence to embark on this journey, without which data science and without which open dialogue, such as this IQ forum, I don't think I would have been inspired to do. So I just want to say that. And to Dr. Sweat's point about starting with conversation and relationship and trust, I think healthcare innovation is going to be very grassroots to legitimately get it done. And it's going to be about relationships. So I was a practicing interventional cardiologist at a salaried position here in town. And really the health system is irrelevant. We have great healthcare in Kansas City in cardiovascular medicine, and I could have been at any one of the institutions. But I just felt like there is so much more I can offer, and I am not able to do that within the confines of a health system that has different goals and values than I do. So I believe in healthcare where there is mystery, there's margin. And we are seeing Ashok's company doing well because we have self-funded employers now who have a fiduciary responsibility to their healthcare spend like never before, that have to pay attention to this stuff. In cardiology, I feel compelled and responsible because I'm the number one source of specialty spend in healthcare. And I feel like I can do something about it with the right partnerships and relationships and the incentives. We talked a lot about incentives today. So I have to be incentivized to lead and deliver the kind of care that my patients want. And frankly, we physicians want to deliver. We have the best job in the world, but if our incentives are not aligned, it is just exhausting. And this is why you're seeing burnout. So if you want to keep docs around, we got to figure out a way to engage physicians in a way that allows them to provide meaningful care, to work with primary care. Primary care is obviously a huge opportunity for us, but we specialists have to be incentivized and aligned in a clinically integrated network that rewards the same things, that rows the boat in the same direction. And that's what I'm on a mission to try to evolve to. So, John, I just want to acknowledge you and for your mentorship. You've been really instrumental.
How's it going?
Yeah, I mean, it's going well. I've had some great discussions in town. Dr. Norman and I and David Nill went out to breakfast a couple years ago, I guess now. And it's very inspiring to meet these leaders in the community where, I'm not going to meet these folks just sitting in the cath lab, loading the truck, so to speak, doing stents all day long. So I'm really interested in where healthcare can go. But yeah, very inspiring conversations. I think the three big opportunities are in Medicare Advantage with capitation. There's a lot of incentive alignment with employer groups and working with groups like Centivo. I'm going to be going to Dave Chase's Rosetta Fest for the first time here at the end of August. And I don't know if you're going to that, Ashok, but hopefully if you are and Centivo's there, I'd love to meet. But I think just getting out of our comfort zone as physicians too, we got to learn the business of medicine and how the money flows in order to make a difference. And then we have to, I think the last thing I'd say is the consolidation of healthcare that promised better quality, lower cost clearly has not worked out that way. So we got to get some more healthy competition in the marketplace. to and pricing transparency to show those who are footing the bill what's possible. So thank you, John.
So obviously I love to talk and I keep talking, but we're coming to the end. Any other questions? And those on the phone, I no longer have Pat's computer to know what the chat says. So just come off mute. But, in the last few minutes, any questions? You've got some real people in the trenches thinking about this every day. And it's a great opportunity to get to ask the questions you have and share their perspective.
This is probably an easy question, but for you, Dr. Sweat, I was literally just talking with somebody last night that I just met, and we got to talking about, she was like, I've had a terrible day. I've been fighting because one of my best friends, twins, are being told that their therapy is no longer medically necessary, and helping them navigate that fun mess. And I'm curious, you mentioned that a lot more employer groups are shifting to being ASO. And so I'm kind of curious in that sense, because they are choosing what things that are and are not covered. It's, why are we not talking about that more as an industry? Because I think, the perception still is very much, well, it's the insurer is making these decisions. And, that was a big light bulb moment to me, that I'm like, well, if they're in an ASO, arrangement, maybe it's not actually the insurer that's making that decision.
Yeah, I was a doctor for long enough to get frustrated with prior auth. I'll just put it out there. And Blue Cross was never the ones that we were always complaining about. And when I got to Blue Cross, if you think about level of intensity, we just, I shouldn't say this out loud, we've never been as intense, or still not as intense. However, when you think about the stuff that comes through our door, 85% of it just whips right through. Don't even look at it. Most of the stuff that you guys, we all ask for just gets done. Of the 15% that is remaining, most of it's approved, 90 to 100% almost in some cases. Of that group, 70% are ASO, not our choice. So you think we're down to 15%, down to 30%, down to 10% that might get denied, and that's a big number. And so a lot of this is not. It's not our call, and a lot of it just gets run through. Now, I will say, however, when you think about what these things are, medically necessary, you said that those are buzzwords. Does it meet medical necessity criteria? Is it investigation? You think about from an insurance perspective, we've got 10 doctors in our building. We don't have a hospital full of people. We've got a bunch of nurses. We've all heard about evidence-based guidelines, right? NCCN guidelines, cancer guidelines. We don't really touch cancer, by the way, but we touch a lot of medication issues. We're not the ones that are going to write medical policy. We're probably late on the end of bringing stuff into the house. I tell people all the time, these guidelines, we don't write them. People like him write them. High quality doctors, the people that are sitting on boards and research foundations and advisory panels. And I used to sit on something around PSA guidelines, prostate screening guidelines. 20 years ago, they're probably long gone, but there was a group of experts that wrote these guidelines that said this is what should be done in these cases. That's what we just follow algorithms. It's not.
So what is the role of a health
Of an insurance plan?
Yeah.
It's a good question. It used to be to take risk. We bore risk for people, and right now we do it for about 30% of our clients. The rest of them, we process claims and manage and help them manage risk. Because if we just give it up, if we were to tell that the 70% of like the Garmins and all those guys, hey, we're not going to manage anything anymore, they want us to manage their claims.
Okay, so my follow-up would be, are health plans actually part of the health system?
That's a good question. We're part of the healthcare economy for sure. Because we, like it or not, that administrative side of the house, it doesn't end with us, it doesn't start with us. If you think there's a broker community, there's an HR group, there's an employee, the HR to broker to insurance company to eventually the doctor. That value chain is far too long.
From the beginning, the first slide had on there, we, and I was sitting here wondering who the we is. By these conversations. I'll tell you what I mean by that. We, as a group, as consumers, as providers, as organizations, there's all these we's, but there's something about who is the we that's going to take some responsibility for the macro decisions that have been made that are so bad that continue to be made. And I'm wondering, I love the last solution on that we heard. I'd like to learn more, like John said. That last one. But with the exception of that, we as a group used to be able to rely not very well on at least HHS and places like that, trying to set policies that made some sense, even if they didn't always make sense. A lot of what we're dealing with today is a result of well before this administration. It doesn't have to do just, but now we're almost in a crisis. Who's taking on, what organizations, what groups are taking on dealing with the bigger picture today? Is there anybody or no? Well,
Not that I'm aware of. I mean,
maybe that's the challenge. Is to come up with strategies for dealing with the bigger picture.
well, the challenge is that we've, I mean, I don't want to get political here, but we have a leadership that no longer cares about truth and fact anymore. They, and that's very challenging to do. I mean, we're worried about vaccines causing autism, and now we've got a measles epidemic. I mean, it's unheard of, and so, we're in a jam. And the repercussions of
Like we're talking about people that are in the rain, they're hitting at us, and we're just talking about how you explore against.
well, the most important thing is to think about what is that great line, Lord, give me the strength to understand what I can change, understand what I can, and the wisdom to know the difference. I mean, we have a very narrow opportunity to make an impact in our community. And, yes, I mean, there was a great question about what's the role of the church company. I was asked to join Blue KC, and I didn't tell them why I did it, but I really wanted to know, like, they were the enemy. Like, what is going on? I really want to understand their perspective. And I have been humbled by how hard Blue KC works to really deliver and improve care. Like, I mean, I did not expect it. I felt like, a Trojan horse. I got in, I was nice and blah, blah, blah. And then I was going to really try and figure out how could they be making so much money and screwing everybody? And Greg's absolutely right. I mean, look at the 990s. I mean, they've lost hundreds of millions of dollars in the past few years. They're trying to do the right thing. And, they have a real opportunity to make an impact in Medicare Advantage, but you can't do something like that if your partner won't dance with you. And so I am humbled by how complex it is and how naive I used to be when thinking I had all the solutions. And the truth is that we've got to figure this out, and I just don't know what the answer is.
Yeah, that's a good question. One thing I would suggest, I mean, if you look at where the money comes from, it's really two sources. Really, it's the government and it's employer.
Yeah.
And there was a bullet. Sorry. Oh, so we have money comes from the government or employers, and there was a bullet point that said that Medicaid pays half of what employers pay. And part of the problem is I would turn that around. I would say the problem is that employers paying double what Medicaid pays. So in terms of an audience that is not activated, and believe me, I've spent years trying to activate them in various roles, employers have got to step up and get serious.
They can, but let's just be clear. I mean, if everybody paid Medicare rates, hospitals would go broke.
That's not true.
No, it's not.
It's not true.
I love the comment.
In Minnesota, the Business Healthcare Action Group stood on Mayo.
Can you go to the microphone so they can?
Sorry, yes.
Yeah.
I mean, I just cannot tell you how this burning platform was not stood on by our employer groups. When I was at Mayo, this is 1997, we had guidelines circulated to the doctors, ICSI guidelines, to use them. Why? Not because of Mayo, because of the Business Healthcare Action Group stood up and said, you will do these things for us. Companies like 3M, this was 1997, 1998. That burning platform doesn't exist in our city. I'm staggered by the fact that they just put up with us as a group. And it's just, so your point about that, the fact that when I was at Advent and I was moving into the physician group side of the admin house, our CFO would challenge me constantly. You need to run those things at Medicare rates. And I thought there's no way. I can't run our clinics at Medicare rates.
But there's good evidence, well, I shouldn't say good, but there is evidence that in markets where hospitals operate at rates closer to Medicare, they can do it successfully.
There's a lot of data out there that lower cost providers provide better quality.
Exactly.
There's a lot out there.
So what's happened is that employers have been subsidizing it to the point where hospitals have been able to hire more people and provide more, none of which contributes to quality, all of which contributes to cost. Because they've been subsidized by.
Well, and I will just say that if this coincides with the misalignment of incentives. I mean, if you know what you're saying and what Greg's saying is that when the payers in Minnesota stood up and said, we're not going to pay over this, that, or the other, they found a way to solve the cost. But a lot of that comes from, I mean, there is so much cost in unnecessary testing and iatrogenesis. And so there's so much money that could be saved by doing that. And, 40% of a cardiologist practice used to come from stress testing, imaging. And we just had the ischemia trial that showed that a stress test did not identify who needed to go to the cath lab or not. Have there been any changes in the frequency of stress testing? No. But if KU or St. Luke's was given X amount to care for all the patients with heart disease, I mean, tomorrow they would stop doing stress tests, I
think one group, in my opinion, that can, because Greg brought this up in terms of we're not able to make the choices. Nobody wants to be told by their health plan that they can't do something. If there's only one group that can do that, and it's physicians.
Well, we've been trying, but we are just, I mean, look, Matt, myself, I mean, we've just been howling at the moon and the moon has not done anything. So I don't know, we'll see but I think you're right. I mean, and how bad does it have to get before we evolve? I don't know, but well, listen, this is great. I mean, thank you all for attending. Thank you online for participating. Both, Ashok, and I think we lost Sam, but what fabulous to have your perspectives, and I am going to get online and learn about Sativa. And Greg and Lee, thank you guys so much for spending your time sharing your perspective, and for the audience with the great questions. So we have our next one in September. Pat will be sending out invites. I sure hope you'll come again, and thank you for being here today.
September 11th, what does a public health transformation look like? I'm not sure if everyone online heard that. September 11th, what does a public health transformation look like? And again, we are so grateful to our supporters for this, the Health Forward Foundation, BioNexus, and to all of you. Thank you for coming to these, and watch for your surveys because we need your input to schedule next year. Thank you, everyone online. Good night.
Hey, see you.